morning, friends. In fact, this session was supposed to be chaired by Dr. Anjana. So I deem it as a great honor to chair the session of Professor K.K. Das. And the topic is on diabetic foot syndrome and cardiovascular problems. You all know diabetic foot. Any diabetic foot is always associated with cardiovascular complications. It is threefold: increase in risk of coronary artery disease, morbidity, and mortality. Maybe due to hemerological, or it may be due to same vessel caliber, or it may be due to autonomic disturbance. To talk to this subject, we have none other than a great Indian personality, Professor A.K. Das, who is like a mentor figure to many of us. And there's a saying that by Alexander Pope, honest man is the noblest creation of God. His profile has been projected there. So with these few words, I request Professor A.K. Das to go ahead with the lecture.
Thank you, Dr. Balachandran, for this generous introduction. Dear friends, thanks to everybody, Jyoti and everybody who are present here. I'll go to, because I have been told that I have to take less than 20 minutes, so I'll take about 17 minutes maximum. Now, dear friends, first of all, why this talk? This is a new concept that has been given, that you think of a diabetic foot, leg, and heart syndrome. We'll examine whether it is possible to have this syndrome or not. Now, what is in this presentation? We'll discuss very briefly the coronary artery disease and diabetes mellitus, which is the most important contemporary challenge in diabetes. We have many screening for coronary artery diabetes. We have the traditional risk factors, we have the novel risk factors, but we have few non-invasive imaging techniques which can be done anywhere by anybody. And my focus today is on that. It's a very small topic, very focused topic. Number two, we'll also see the people who had poor food, that the ankle brachial index was not compared to the angiography, the gold standard of coronary artery disease. So we have some data done by my postgraduate Sukesh with Balachandran. I will show some data regarding the correlation between the angiography and the ABI. Now, dear friends, I have Georgie in front of me, my colleague, and Georgie took last week a class for our undergraduates on the cardiorenal syndromes, all the 5 types. We have cardiorenal syndrome in diabetes. We have the renoretinal syndrome in diabetes. Now, we have to think whether diabetic foot and heart syndrome owns the merit to be talked so, and what is the burden of proof, and what is the utility of this nomenclature, calling it as a cardiorenal syndrome, a foot-heart syndrome. And we'll discuss the most important, the ankle brachial index and the cardiovascular mortality. 75%, coming to that, what is the mortality with the low ABI, and what is its contribution to the RIGOCORE study, and what is the abnormally high ABI, and what's its contribution to cardiovascular mortality morbidity. We'll examine both. I'll discuss 2 new concepts. One is the adiprovascular complex. It is a concept that how the adiponectin deficiency, or whatever the adiponectin abnormality, how does it affect the vascular access. I'll also demonstrate in very briefly how does the immunomodulators and how does the inflammatory markers also affect the vascular system and the diabetic foot. I will present own data, this showcase my postgraduate's data. I'll discuss many studies, but I'll emphasize only 2 studies, lack of time: the strong heart study and the multi-center study regarding this particular aspect, and we draw some conclusion. Dear friends, does there exist a connection between the diabetic foot and coronary disease? Does there exist a correlation? Now, this is how the diabetic foot evolves. We have the long duration of diabetes. So, we have the duration, we have the chronic hyperglycemia, we have hypertension, we have dyslipidemia, we have elderly patients, we have chronic renal disease, and we have PVDs. Please concentrate for a minute, and you will see that all the general factors written on your left are definitely the factors also for the cardiovascular disease. Whether it is hyperglycemia, whether hypertension, they are the factors for the cardiovascular disease. On the local factors, again you will find that peripheral neuropathy, which my friend Bala told just now, the autonomic dysfunction, which goes pari passu with the small fiber neuropathy, is also affects the heart disease. So there is a connection between the two, And if you go through the pathogenetic pathways, you will also find that the neuropathy and vascular disease go hand in hand, and both have a component in the heart disease. Needless to mention, the most important issue that 80% mortality and 75% hospitalization because of coronary disease and diabetes mellitus, and those who have diabetes will develop coronary disease in about 3/4 cases. Peter Geddes. Now, if we want to do a cardiovascular risk assessment in the asymptomatic adults, we have the predisposing factors, the gender, the family history, the other genes about which we cannot do anything. We cannot choose our parents, few youngsters can choose their in-laws. About the behavioral, we can modify it. We have the diet. Mohan has given beautiful exposition. He is going to speak about it, I am sure. The physical activity. Anjana is not here. She has shown the beautiful document about the sedentarianism, which is about 71%, and vigorous exercise 4.5% in our Iceman DAB study. I will not present it, it will be published shortly. The smoking. These we know the behavioral factors. We have the metabolic abnormalities, obesity, we have got dyslipidemia, hyperglycemia, hypertension. We have got the stress, calcium score in the coronaries, we have the various types of acute phase reactants, and we have the LVH, and this can produce the overt cardiovascular disease in diabetes mellitus. Now, there are modifiable risk factors, non-modifiable risk factors, and we have various types of risk scores, UKPDS engine, the Framingham engine, and we have the various risk factors. I have shown one risk calculator, the Framingham risk calculator. Now, today's world is moving, there is a paradigm shift from the traditional risk factors, in addition to traditional risk factors, to the novel risk factors. What are they? Ankle brachial index, I will come in a minute. The CIMT I will not discuss, even though it is done by my PG in this particular study. HSCRP, I will just show one slide. Fibrinogen he has done, homocysteine he has done, lipoprotein literally he has done, and the TPAPI he has done. I will confine my talk only to the focused area. How does the ankle brachial index correlate to the CVD? Dear friends, if you see the biomarkers for the future cardiovascular disease in diabetics, there is a galore. The whole thing I have shown in the table. You will find that all this is responsible. But is it possible to all these in a peripheral setup to know whether the man is prone to diabetic heart disease or not? Now, there are acute phase reactants. We have the high sensitive C-reactive protein, and this is the famous Redeker study from the Stockholm, from the famous Karolinska Institute, where I spent some time. It shows the C-reactive protein, how it goes along with the cardiovascular risk, and the Zipper study, and I will show the table that we take positivity beyond 3.08, and we found both in diabetics and non-diabetics with the acute coronary syndrome. With the acute coronary syndrome, the HSCRP goes up as the acute phase reactant. May not go up with the MI, stable MI, but acute coronary syndrome, it goes higher. And it also goes higher with the ST elevated MI, non-ST elevated MI, and unstable angina. So, HSCRP has a correlation with the heart disease, and when we correlated with the angiography done by Balachandran with the same patients, we found that there is a linear correlation between the single vessel, double vessel, triple vessel disease and the HSCRP. I'll finish the story there itself. Now, today there are two other things which are gaining importance. One is the epicardial fat. Epicardial fat as a sign of inflammation, and epicardial fat as a risk factor for the diabetic heart disease, and also the role of the adiponectin. Now, it has been shown that epicardial adipose tissue are known causes of CAD and adiponectin associated with the CVD. However, the expression of the adiponectin on the epicardial adipose tissue and how does it produce CAD is not yet clear. Now, there are various studies, histological examination, do details of it, but suffice it to mention that epicardial adipose tissue is strongly correlated to the severe risk in diabetes mellitus. Now, I will not go through the various update on the role of markers, I will omit it. I will confine myself to the one single non-invasive screening method, the ankle brachial index, and I will not go to details. Suffice to mention there is CIMT, which is done routinely, coronary calcium score, the MRI, the endothelial function by the flow mediated velocity studies, the arterial stiffness studies by the various pulse waves. I will confine myself to the ABI. Now, why do we non-invasive screening? Angiography is gold standard, but it has got its complications, especially the patients, George's patients, who are renal failure, who constitute a large number of cardiac patients. Number two, angiography, if it is done in the early phase of atherosclerosis, it limited to the intimal wall. The disease related to intimal wall is not picked up the angio. It has to obstruct the lumen. This issue can be solved to certain extent, not fully, by the non-invasive test. ABI, needless to mention, quick, simple, non-invasive. The machine costs only 8,000 rupees. We can know the arterial disease and diabetes mellitus. There are also automated machines which are available, which give the results in a minute. And ABI of about less than 0.9 is considered abnormal, and has been shown in various studies. I have given the references. 95% sensitive for the angiographically verified peripheral artery disease. Now, there are various studies which have highlighted the role of ABI when less than 0.9 as an independent marker of the CVD of a significant atherosclerosis, and also the ABI decreases, the number decreases as the severity of stenosis and the number of stenosis and the number of vessels involved in diabetic heart disease. This has been shown by various others and also shown by our study. I'll go to the published paper which I brought for you here. But there are some drawbacks. ABI can be faultily raised. People who have the severe disease in the smaller arteries of the legs, ABI may appear normal at rest with significant disease when the arteries are in the pelvis. It doesn't pick it up. Therefore, we have a toe brachial index which is practiced, which is better than the ABI, and also ABI after exercise can constitute a little bit of replacement for the advanced test. Now, in the Zipper study, a mean ABI of 0.85, both in diabetics and non-diabetics, were admitted with ISD, showed that there is no difference between the diabetic and non-diabetic, but this is a good marker for the coronary artery disease in both the groups. And ABI of less than 0.9 showed a good sensitivity in that study, 72.8%, and high positive predictive value of about 97% for this. And this shows the various types of, it is combined together ABI and CIMT, and it shows that how ABI 0.9 and below was beneficial, its relation to CIMT, a relation to the various types of various number of vessels involved in diabetic heart disease, and how it stood out as a test for this particular disease. Dear friends, I will just tell you that if you do a coronary angiography, it has been shown that there is a galore of diabetic heart disease in the diabetic population. The Peter Graded study showed that there is increased incidence of triple and the double vessel disease. Now, before going to angiography, can we have a small screening test to know that diabetes mellitus has produced this type of disease? There is a small table which shows two things: percentage of arterial segments with and without atherosclerotic lesions when the ankle brachial index and the diabetic foot syndrome is present, and the second one, the distribution of the atherosclerotic lesions in the arterial tree. You will find that the lesions which are really unique to diabetes or more common in diabetes, like the superficial femoral, the popliteal, the tibioperoneal, the tibial, the peroneal and the posterior tibial, you will find whatever we find in the angio is reflected with the ankle brachial index values and the percentage of arterial segments with and without lesion, and also the distribution in the general arterial tree. There is a study which shown the high ABI is associated with increased CV disease morbid mortality. This high is what is above 1.4 because of the calcium in the arteries, because of the medial MAC, medial arterial calcinosis. So, I have shown the data for the low ABI, but when the ABI is astronomically high, beyond 1.4, it also decreases quality of life. There is a study called partner study, that is the PAD, peripheral artery disease awareness, risk and treatment study, new research survival study, which shows a national cross-sectional study of almost 7,000 patients aged 50 years. It showed that high ABI also equally treacherous. They compared with those with a normal ABI. Individuals with a high ABI have a significantly higher odds ratio for all types of vascular disease, congestive cardiac failure, strokes, foot ulcer and neuropathy. Dear friends, there is a study, as you know, a very famous study called REGICOR study, and adding this low ankle brachial index to the classical risk factors has improved the prediction of the major cardiovascular events in the REGICOR study, and therefore the ABI was included in the study at the late stage to improve the sensitivity of the particular study. I won't details of it. You see, they took so many factors, but the ankle brachial index was very helpful when they added to it. I will not details of it, I will not go into it. Now, is it a one-way fact? Like the cardiorenal syndrome, we have the diabetes with renal disease and renal disease with heart attacks. And what does the heart disease produce in the kidney? It has been also shown that if a patient develops ischemic heart disease and congestive cardiac failure, it predicts delayed diabetic foot wound healing. That means there is a two-way lesion. I think there is a talk about the two-way path we'll be seeing from Dr. Sarita Bajaj's talk today. He is showing the periodontal disease, the two-way disease, diabetic affecting the dental periodontal disease and periodontal infection affecting diabetes. So this is something like that congestive cardiac failure itself produces delayed diabetic foot healing. Now, this is the finding of about 107 consecutive cases. The graph shows that with the comorbid congestive cardiac failure, the wound healing was delayed for a very long time. I have come to the end of my talk. I told a very small talk. Diabetic foot syndrome is a possible cardiovascular marker in diabetic patients. And people who have cardiovascular foot ulcerations are forerunner of the vascular complications and associated with a high degree of morbidity and mortality. Now, there are two markers. One is called IL-6, other is called resistin. And there is an axis called adipovascular axis, and this axis contributes through this mechanism. One is the adiponectin, adipose tissue mechanism, and other through the inflammatory mechanism in producing both diabetic foot syndrome and also the heart disease. So, in patients with diabetic foot, this adipovascular axis expression in lower plasma levels of adiponectin and higher plasma levels of the inflammatory markers is linked to the pathogenesis of the heart disease. This is one of the proofs that has come. The other one, as I said, is the immune modulatory features or immune inflammatory features. There are immune activation at various stages of the development of chronic wound in diabetic foot ulcer. I will not go details of it, but this immune inflammatory upregulation may precede the full-blown DFS, and same way it can produce the major cardiovascular diabetic complications such as CAD. Now, I have given the data for this. This is our publication. They comparing the diagnostic utility of ankle brachial index and carotid intimal thickness as surrogate markers of the significant coronary artery disease in Indians, and with increasing severity of CAD, the ABI decreased as expected. If you compare the diagnostic utility of ankle brachial index and CMT, we found that the ABI CMT are simple non-invasive tools providing insight into coronary atherosclerosis. And again, the relation between the ankle brachial index and the complexity of the coronary disease in the older patients has also brought out in a different study, and it showed that even with a very severe diabetic foot disease, one can expect very complex coronary disease. And I will not go details of it. Now, in the strong heart study, I have finished. It has shown, I will just come to the conclusion that it is a very famous strong heart study. Association between the high ABI and mortality is similar between the association of low ABI and mortality. So, there is a U-shaped association, but more often with the low ABI. Therefore, the upper limit of the ABI should not exceed 1.4, and below 0.9 it is possibly an indicator. Dear friend, I will conclude by saying there is strong evidence and there is data suggesting a link between diabetic foot, either in association or in very strong relationship to cardiac disease and diabetes mellitus. We know diabetic foot is my foot disease. Nobody cares for it. It is a syndrome of diabetic complication. In spite of, we have the rule of 15, where 15% get it, 15% lose that, and another 50% they get the other limb amputated next year. So it is rule of 15, rule of 50, but nobody pays attention. Now, I thought in association of CVD, diabetes mellitus will make both the persons, that is the persons with diabetes and also the healthcare providers, conscious about diabetic foot, because any matter of heart is given importance. And above all these associations, starting from cardiorenal, renoretinal, metabolic syndrome, all that is justifies, all this syndrome justifies that you have, if you have one, look for the other. If you have the MI, CAD, look for the foot complication. If you have the diabetic foot disease, look for the heart disease. Thank you very much for a patient hearing.
Thank you, Professor Das. So it's a very thought-provoking lecture. He has highlighted the importance of cardiovascular complications, both in neuropathic as well as vasculopathic ulcers. And he also highlighted the importance of hsCRP, epicardial fat, adiponectin as a major risk factors. One single non-invasive investigation which he stressed was the ankle brachial index, a good marker for coronary disease.